Gossip.
This is Polyp Gossip, the place for physicians and patients to catch up on what's hot and what's not in CRS with NP or nasal polyp syndrome.
This podcast is developed by Sanofi Regeneron and also elaborated in close collaboration with EUFOREA. Welcome to this fourth episode of Nasal Polyp Gossip, which is all about to cut or not to cut for patients with CRSwNP. This is indeed a very hot topic reflecting the revolution of care in the field of treating patients with severe uncontrolled chronic sinus disease with nasal polyps. And I'm so happy that we can gossip around this topic with top experts in the field, coming from Germany, Professor Martin Wagenmann, from Belgium, Professor Philippe Gevaert, and from the Netherlands, Professor Wytske Fokkens. These three do not need any introduction because they are considered key opinion leaders in the field, and it's so nice to be able to discuss with them in this informal setting about considerations around sinus surgery or biologics for our patients suffering from chronic rhinosinusitis with nasal polyps. So happy to launch this fourth episode of Polyp Gossip with you, and I'm very excited to have you here to launch the first question. Let's kick off this Polyp Gossip episode with the first question to Professor Martin Wagenmann about what kind of patients you would propose a non-surgical option like biologics if he or she has had sinus surgery before.
Well, obviously, these need to be patients that fall within the indication for the biologic. That means the patient, first of all, needs to have problems, symptoms mainly, and we need to see bilateral polyps, again, recurrence of polyps. And in this case, we want to make sure as good as we can that the patient suffers from type 2 disease, assuming that he didn't receive any biologic treatment before. So this is important, and of course it is very important to make sure that the patient already received, in addition to previous sinus surgery, proper chronic treatment with intranasal steroids.
Okay, would my colleague Professor Gevaert agree on those statements, or would you add also patient symptoms and other considerations in the equation?
Of course, symptoms is important, so we have to know the impact on the quality of life. You can have polyps with little symptoms, but many of our patients have a lot of symptoms. Smell, for example, is very important, and if you have no smell, I think that's very important for the patient. It's an important question. But for me, I think also comorbidities are important, like asthma and ERD are important to take into consideration when you go for a biological, because you know they will work on the comorbidities as well. So that will help me in making my decision.
Okay. Now I address this question also to Professor Wytske Fokkens, talking about, for instance, smell loss in a patient with severe CRSwNP who had previous surgery. What would be your approach, and to what extent would you opt not to cut, or would you still go for a revision surgery? So what considerations do you take into account?
Well, of course, smell is extremely important for the patient. And the first thing I would like to know is whether there is still possibility of improvement. So we try to find out together, the patient and me, whether he is still able to smell. And one of the things you can do to try to find that is discuss the last time the patient had systemic corticosteroids. If the smell improved on systemic corticosteroids, then very likely it will also improve on biologics. If not, then we have another discussion, because the effect of surgery on smell is usually, especially revision surgery, not great. So if smell is an important issue for the patient, that would guide me to one of the arguments to discuss a biologic. But of course, we have to know that the smell can still be improved.
I couldn't agree more. We have Another point raised by Professor Gevaert, which are the comorbidities. So I wonder, and I address this question to you, Martin, to what extent you think also comorbidities are a decisive factor in order to drive your decision for more or less surgery in a patient?
I think they're very important. I mean, for the patient itself, and in this population of patients with severe chronic rhinosinusitis with nasal polyps, we do see like at least half of our patients, actually looking at the current number, almost 2/3 of these patients in our clinic actually suffer from asthma. Not all of them know about it, so it's very important that we ask the patients for symptoms. Sometimes they never saw a pneumologist, which is of course not good. So this is a very relevant factor, and among the possible comorbidities, asthma is not only the most prominent, the most frequent, but also the one that is most impactful on the patient itself. So already at this point, we need to get into contact with a pneumologist and ideally steer towards a common idea how to treat the patient.
We have indeed seen that in asthma patients with severe CRSwNP, biologics work very well. Also, surgery is often performed in those patient populations. Philippe, how do you see the impact of asthma on the outcomes of sinus surgery in that patient population? Are these outcomes equally good or less good in a patient with comorbid asthma, and how you discuss that with your patient or with your pulmonologist?
Well, I work together with pulmonologists every week, and we discuss those patients also every time we go for a treatment plan. And I have to say that when I was young, I went there to catch surgeries. Today, I go there to see that my patients with severe asthma on a biological, most of them don't need surgeries anymore. And of course, there are some patients that still need surgery because it might not be the full response they have on the nose. But first of all, they are rare. And second, that's also a kind of patient which is quite often harder to treat. So we are talking about university hospitals with extremely difficult patients, and there we do surgery together with the biologicals, and sometimes that's a fantastic effect. Sometimes it's a little bit disappointing, I have to say. But again, we are talking about very exceptional patients. Most of the patients that are on a biological for asthma don't need surgery anymore, even when they didn't had surgery at all before.
We are talking just about surgery here, Wytske, but I would like to have your opinion on to what extent we make a distinction between primary surgery and secondary surgery. I mean, revision surgery versus the first surgery for severe CRSwNP, how you see there the impact and the interplay with biological treatment.
Yeah, that's a very good question, Peter. I fully agree with Philippe that biologics work with or without surgery. And if that would be the only factor we have to take into account, then you could argue and say, well, try biologic first and don't do surgery at all. But of course, biologics are not for free. It's still an expensive treatment. And in most countries, they are paid by the healthcare payers. And in that sort of situations, of course, we have to be careful that we do not prescribe unnecessary. And as long as biologics per year is considerably more expensive than one surgery, which usually lasts more than a year, I think there is a very good reason to, well, apart from very exceptional situations, to do surgery first. Surgery is effective if we say revision surgery is only needed in about 20% of the total population of patients with polyps. And of course, in a university hospital, we always think that figure is wrong because we see so many bad patients. But in general, 80% of the patients do well. So I think there's a very good financial argument, to do surgery first.
Yes, Martin, you want to comment?
Yeah, I would like to come back to the point we had before, because I think that's important. How relevant is asthma? And you asked the question, does it have an impact on your recommendation for surgery or not if the patient suffers from asthma? And we do know from experience and also from numbers that actually the patients who have asthma in addition to chronic rhinosinusitis with nasal polyps have at least a higher likelihood of recurrence after surgery. So, I mean, it's not that every patient with asthma and nasal polyps should receive biologics. But if I'm in a situation where I have to decide together with the patient, will it be biologics or will it be surgery, asthma, if the patient suffers from asthma, that from my point of view would speak a little bit more for biologics as opposed to surgery.
Mm-hmm. I fully agree with you. We have worse outcomes after sinus surgery in those with comorbid asthma or comorbid allergies than in the ones without. And even more so in those with a positive history of aspirin intolerance. Philippe, could you comment on those?
Well, we know from the studies that they have worse outcomes after surgery, like indeed with allergy and with more severe asthma. We currently don't do the aspirin provocations anymore. So what we do is we just do by history taking. We ask them whether they reacted on them. So probably we are underestimating the number of patients in our population there.
Would you agree on that, Wytske? Those with aspirin intolerance are often remaining under the radar of diagnosis, and therefore, if they undergo surgery, they may have a very high recurrence rate due to the fact that there is also this aspirin intolerance giving rise to recurrent disease.
Yeah, I agree. Yeah, but I think when there is an indication for many of those patients, there is also a lower airway indication for a biologic. And then, of course, the decision is very easy. The question is the patients that do not have a lower airway indication for biologics, so the asthma is not that serious, not that bad, and do we take it then into account? And I think most of those patients with aspirin intolerance usually also have quite severe asthma, so they also have a lower airway indication. And that, for me, makes a big difference.
Yeah. We wanted to have here a kind of appealing title for this first episode, which is to cut or not to cut. But could we specify what we mean by cutting or what we mean by sinus surgery? It's an ongoing debate, and I see Wytske laughing, so maybe you first, and then I hand over to Martin.
Well, you know, I learned a lot in the COVID period. When we were able to start prescribing biologics in the end of 2019, before COVID, we said, well, at least the patient need to have had proper surgery. Well, what is proper surgery? That's a very good question. But we said, well, full adenoidectomy, draft 2A, that's proper surgery. Many of the patients that were referred to us did not have that extensive surgery done. Then we ended up in COVID, and in my hospital, we could only operate head and neck oncology, but to operate on a polyp patient was extremely difficult. So we had a sort of ethical discussion. Do we really say to all these patients, wait till after COVID before you can have a biologic because we feel your surgery is inadequate? And we had no idea how long that would be, or are we going to treat? And we decided to treat them. It did not make any difference. So it taught me that my opinion about the extent of the surgery as a preliminary indicator for giving a biologic yes or no in revision surgery was wrong, and that it doesn't make any difference.
That's indeed very interesting, and happy to hear Martin's comment on that.
Well, in general terms, I would definitely agree with Wytske, and we see the same. I mean, every so often we look at a CT scan or put the endoscope into somebody's nose and say, maybe the surgery wasn't really perfect that you had. But indeed, in many of these patients, a biologic wouldn't work less well in these less perfectly operated patients. But maybe we can try to differentiate a little bit more here, because there are some, it's not always black and white. Sometimes it's gray. And sometimes the patient has, symptoms, but I believe the type of symptoms that the patient have or has is relevant also to the decision between surgery and biologics. So in a patient, we discussed smell loss. Yes, of course, perfect indication. But what about patients where secretions or maybe even pressure in the face, headaches, is more relevant for those patients? Those would be patients where I would tend a little bit more towards the surgery, although I'm not aware of any studies looking at that specifically, but that's my clinical feeling. I don't know if you have the same.
Quite often it's not or surgery or biologics. Sometimes it's a combination of both to achieve the best possible outcomes. Would you agree on that, Philippe?
Well, I agree on that. I think what we learn from oncology is that combining strategies is quite often better than not doing that. But if I may, I want to come back on what Wytske was telling. She told us, or she learned us, that the outcome doesn't matter whether you had extensive surgery or not. That's true if you already consider giving biologicals. However, if you have a primary patient with primary polyps coming in, and you have to decide what type of surgery then you do, I think we all agree that a complete ethmoidectomy with removing as much as possible the polyps is the first step to go. Because if you do a good surgery from the first time, the chance that your patient, a primary polyp patient, not with severe asthma, still needs a biological will get smaller. So I think, and also some studies now in Finland show that this kind of polypectomies or very small surgeries as a first step is maybe not the best thing to do. Of course, if we have the intention of putting everyone on a biological, it won't matter. But if the intention is to only put the 40% more most problematic patients on a biological, then it matters what your first surgery is like. I do not know, Martin, what you think about that.
I would agree, but I would also, what I always discuss with the patients, if we're talking about primary, the first decision, surgery versus biologic in a patient who didn't have surgery yet. I think one of the very important arguments for surgery is that this is really, in many patients, actually in the majority of the patients, if you see the whole population, this is a disease-modifying treatment. You perform the surgery. If you continue treating them with intranasal steroids, with nasal washings, you have a more than 50% chance that the patient will not recur, that polyps won't recur, and no need for continuous treatment with a biologic or with steroids. And that's, I think, it needs to be discussed with the patients. I mean, sometimes patients come to me and they say, no, the surgery is terrible, it's dangerous, I don't want surgery.
Well, in the next episode, we'll discuss personalized treatment and how to make a patient turn into a satisfied one. For now, I want to stick to the surgery and know what are you aiming for with the surgery or aiming for with the biologic, because that's also part of the equation to cut or not to cut. What is our aim of surgery or what is our aim with biologics? So how would you define the targets of your treatment? Let's start with biologics. What are you aiming for, apart from just symptom reduction? Do you aim for control, remission, long-term remission, or maybe that's a good topic to discuss now?
I think that's a very good topic. I mean, of course, our aim should be to heal the patient, but that's, not always feasible. So control is always what happens first. Control is a prerequisite for remission. If the symptoms are not controlled, he can't go into remission. But that's also something that needs to be discussed with the patient, because we need to work together there, but that's what we're aiming for.
And if a patient asks you, and maybe I address this question to Philippe and then to Wytske, if a patient asks you, okay, what is the likelihood of me achieving remission with either revision surgery or with biologics, what will you tell a patient?
That is very dependent of what the patient has. If the patient has polyps, no severe asthma, no aspirin intolerance, no allergies, then the likelihood that with surgery you will get a cure is even, it's not, it's there, it's like 30% in that kind of patient at least, and that they are well controlled over a longer time is higher. If your patient has all the comorbidities, then the chances are shrinking very fast. And then I think you cannot promise this kind of cure remission thing without the help of a biologic. So I think you have to be realistic. In a patient with only polyps, I think surgery is the first step and the best thing to go. In a patient with all the severe comorbidities, I would say I would do surgery, and if I see everything goes wrong too fast, we will have to help you further and get you on a better track with the help of biologicals.
Back to Wytske now. Wytske, what's your opinion on this target and aim of treatment? What are we aiming for with the biologic versus revision surgery?
Well, as I said before, I think it's very important to discuss with the patient what the patient wants from the treatment and what are the most important things the patient wants to improve. For example, if a patient says, oh, I have terrible postnasal drip, that's not something I'm going to promise with any treatment that it will totally go away. If smell is the thing, I will tell the patient that in my hands at least, a biologic has a better chance than surgery. But if obstruction is the main issue, and the patient wants fast relief, well, surgery can really solve that problem very, very fast. So I do not think you can say one or the other, but that you have to discuss with the patient what the patient wants to achieve, and also what the history of the patient was, especially if the patient had earlier surgery. Was he very compliant with all the appropriate medical treatment we gave him? How many other factors were there, allergen provocation or occupational, that's part of the equation. So as Martin said before, it's not black and white. It's an extensive discussion with all the pros and cons. Some patients hate needles, think that that's a real issue. Other patients say, oh, I have to give myself an injection. Oh, only once every 2 to 4, maybe 6 or 8 weeks. No problem at all. So all that needs to be discussed, and then we choose together.
So now we discuss more with the patient than we used to do 5 years ago, which is interesting indeed. I would just like to have brief comments of each of you before we close this episode about how you feel as a surgeon about the availability of non-surgical options that are actually also considered to be very effective, safe, and appreciated by the patient. So Martin, how do you feel about this novel era of availability of biologics for a condition that we used to treat only with steroids and with surgery in the past?
Yeah, I mean, let me start this way. I definitely perform less revision sinus surgeries than I did 10 years ago or 5 years ago. There's no doubt about that. Typically, these are not always the operations that are the easiest to perform, or let's say the most fun ones. And we don't run out of business. I mean, there's so many patients. It's actually, even as a surgeon, I think it is wonderful that we have this option, that we do have choices for treatment to offer for the patients and for ourselves. So I think that's good. I don't feel bad about the option.
That's a nice statement. Philippe?
I'm very happy that we now have a parachute for when polyps come back too fast after my surgery. So, of course, when we do the surgery, we do the extensive surgery, we hope it won't come back. But we know that in some cases it comes back, and then you at least can offer something. And that makes me more happy as a surgeon, because I can offer something else. Or I can offer something when the polyps come back too early. And that makes my life better, actually.
So you look happy, Martin is happy, and I wonder whether Wytske will be happy too. No. Please explain and clarify.
I think these are very polite answers, but it's not the truth. You know, in former time, we were we were the final professor where the patient came who was in desperate and nobody could do any good. And we knew how to fly low. And with a combination of surgery and appropriate medical treatment, we kept patients well, and they were all very thankful for what we did. Now, I indicate a biologic patient goes to the nurse, and the nurses can do as good as I can do. So, of course, this is joking, and I'm very, very happy for all my severe patients that they don't have to be operated again and again and again. But for us, as the ones who treat these patients, I really think it's great for the patients, but it's less fun for us.
Well, if I may make a final statement, I think it's less fun for us, but it's also good to see the satisfaction coming from patients because they feel more satisfied and so on. So in the end, this is a nice format where we can express our opinion in an unbiased way and where we can even make jokes and, and upset some people, but then in the end, we agree this is a joke. So we have come to the end of this fourth episode of Nasal Polyp Gossip, and it was a pleasure to be here accompanied by top experts in the field, Martin Wagenmann, Philippe, Gevaert and Wytske Fokkens. And we look forward to the next episode, episode number 5, which is all about personalized treatment for CRSwNP. In the past, we only had steroids and surgery, but now we have more options, as you heard. And what we have discussed here is actually paving the way for the episode 5, which we all invite you to join us and listen quite soon. Thank you so much.
Gossip. This was Polyp Gossip, sponsored by Sanofi Regeneron and developed in close collaboration with EUFOREA.